All right, guys, this is the first episode of the three P's in the pod. There's no way you're naming that three P's in a podcast.
You should at least make a pharmacy pun out of that, like peas.
Okay, we're
peas. No,
this is the LexaBros podcast.
LexaBro Pascal.
I don't care.
We're here joined with Kale. Say hi, Kale.
Hi.
And this is
Brian, that's
Brian.
my girls.
So we are currently second year pharmacy students on our last block here at UC San Francisco. Yeah, this is just gonna be a pretty chill podcast. I don't know. Just like talk about random stuff. So this first episode I originally wanted it to be giving to future P1s of School of Pharmacies and maybe even UCSF. So just giving some regular advice. So start off introducing yourself. Kale, can you tell me your background and your favorite, why you chose UCSF, and then your favorite block so far?
Why I choose my background is in chemistry. I graduated Harvard College in 2022, with a degree in chemistry and classical studies. I chose pharmacy because I liked chemistry and I like drugs. But I chose UCSF mostly because of their 3-year curriculum and accelerated pathway. I wanted to get into the field as soon as possible. Also, San Francisco is close to home, so I wanted to be close to home. What was the last question? Oh, favorite block. I think so far I liked oncology the best. I really also like renal. I think oncology was the most interesting. Renal was when everything started to first hit, in terms of everything started to connect, at least for me. That's it.
Yeah. Surprised you like oncology though, Kale, because I remember our group chats for oncology would just be, are we supposed to know this for the exam?
that's for
Is this
exam.
covered on the exam?
That's just for the exam though. The exam, exam is not very definitive of what real life is like. So I think
Fair.
in real life I would enjoy it a little more, especially because I like the math that we do.
A lot of math in oncology block for sure. And what were you, Brian?
Yeah. Hey everyone, I'm Brian, like I said. I graduated with a background in biological sciences. I graduated from UC Santa Barbara back in 2022. Similar to KO, the reason why I chose UCSF, I guess before I get into that, why I like pharmacy, it's more of a personal story for me personally, just as I come from like a immigrant background and I'm the first English speaker in my family. And because of that, I've had the fortunate opportunity to be that point of contact for a lot of my family's doctor's appointments. And I'm usually the one that helps manage my family's medications. They're the ones that come to me for questions, as I'm the one that usually do the communication with the doctors on the behalf of the various family members that are on medications. And so, yeah, I thought that pharmacy was probably the most ideal career path for me. Also, like many of the people that come to, the field of pharmacy, I do like chemistry. And so, fun fact, I did like enjoy AP Chem in high school. That's my favorite subject. In terms of why I chose UCSF, I'm really like KO, I really like the accelerated program, the 3-year program, and just being able to just get right to the career right out of school. I also really like how UCSF is very keen on clinical sciences, and they're usually the ones that spearhead a lot of these new efforts, such as like pharmacogenomics, as an example. They do a lot of these and develop a lot of these firsthand, and so I really like that innovative aspect of UCSF that provides to the healthcare world. And I'm also very interested in doing like research. And so part of our curriculum is to do like discovery project, which is like a almost like an intensive research project. That's a longitudinal research project starting in our P2 year. So currently that goes into our last year, which is next year of pharmacy school. And I've been fortunate enough to partake in 2 of these research studies. And it's been a really rewarding experience for me personally, just from a learner's perspective. Yeah,
Favorite block?
favorite block. Favorite block, probably cardiovascular.
Mm.
I think it's one of those diseases that needs to be managed chronically.
Mm.
And as I thought about just like what I want to do in terms of my career as a pharmacist is treating patients chronically, or like having to help patients through their chronic conditions.
Mm.
One being like cardiovascular, or even like endocrine block, where I help patients maybe manage diabetes, for example.
Mm.
So I think those two blocks are now my favorite so
Mm.
far.
Yeah, that actually gets me to a good point. Sorry, Kay, I know you're eating, but Brian shared a little bit about what he wants to do in the future. What do you want to do in the future? Where do you see yourself in the field of pharmacy?
I think there are two possible routes I can go right now. AmCare, similarly to Brian, is one pathway. I do also enjoy watching patients chronically. That sounds kind of weird, but I like to see growth and that person-to-person contact.
Mm.
And another option would be something that's in between acute care and AmCare, which is kind of like oncology, where you are managing them long term, but you do see them in the inpatient setting. Or for example, like transplant, where they are in hospital for a little bit, but they also go outpatient, and you can manage that chronically. So I guess something in between those two would be like transitions of care.
Mm.
I don't know how interested I am in that yet, since I haven't really seen it in person.
Mm.
But those are the paths I'm kind of looking at.
Yeah, and for those who don't know what AmCare is, it sounds a lot like ambulatory care, right? Can you I know there is no aspect of ambulances in ambulatory care. Can you tell us a little bit more about what AmCare means in terms of like pharmacy and what they do to patients?
Is a free question? Okay, yeah. So ambulatory care, like Emmanuel mentioned, has really nothing to do with like ambulance. It has nothing to do with like emergency medicine, but rather it's more typically an outpatient clinic that is part of a larger institution or hospitals. And at those outpatient clinics, typically patients come in for follow-ups on their disease states, to give it diabetes, or cardiovascular like hypertension, or maybe something like their atrial fibrillation kind of conditions, or just something like long-term chronically. Like there are medicines or medications that are guideline directed to help patients manage and lower their risk of furthering their diseases long term. And part of what ambulatory care pharmacists, what they do is they look at the patient kind of holistically and kind of provide like consultation services to help either manage or modify their therapy or regimen at the time, or can offer resources and guidance, or even like just connections to other specialists in regards to like lifestyle modifications, like things that are non-pharmacological as well. They provide those information to help patient manage the diseases in a more manageable way, but also helping them to kind of slow down that progression of those chronic diseases in a way that is manageable and that is measurable in a patient's lifestyle typically.
Can I add something?
Yeah.
In California, it's great as a pharmacist, because some institutions you can have a what's it called, a connection with a doctor, and in California, pharmacists are allowed to edit certain medications. So if you're in a cardiology clinic, you can, as a pharmacist, you can edit their cardio medications, because you're seeing them more often than their doctor. And so let's say their blood pressure is too high or too low, you can edit their blood pressure medications as needed without them having to go through a doctor.
Yeah, you're mentioning the term collaborative practice agreements.
Thank you.
With physicians. You can even prescribe. You'd be allowed to prescribe your own medication. So thank you for that. Ambulatory care is, when I entered pharmacy school, ambulatory care was very weird to me, because I was like, wait, we get to be in ambulances? No, that doesn't sound kind of real. So you've heard from these two. My name is Emmanuel. I've graduated from UC San Diego. similar to KO, I studied chemistry as well, and I minored in biology. And similar to these people, I loved organic chemistry. I tutored it in the past. And it's really interesting how like a small pill can really change your life. Can lower your blood pressure, increase your blood pressure, lower your heart rate, all of these amazing things that a simple pill can do. And as of currently, my favorite block still stands to be the block that we're currently in. There's an ongoing sort of joke that happens in the School of Pharmacy where people are saying I'm really in love with infectious disease, and I do enjoy it a lot. Um, and you heard about KO wanting to do some acute care, maybe some ambulatory care, Brian wanting to do some ambulatory care. I am the extremes of them. So with Brian wanting to do ambulatory care, I like to do more acute care settings where I see patients who are really sick and I help them get better, whether that be infectious disease or any other illness that they have that forces them to be in a hospital setting. So I really enjoy infectious disease because it allows me to cure a patient. So with Brian's diseases like diabetes or hypertension, those aren't really curable, sadly, as of today. But with diseases such as infections or viral illnesses, they are curable, and you progress to a better state, hopefully. So yeah, that's a bit more about me. I love acute care, and yeah, my favorite block has been infectious disease, but I think if I were to choose between the blocks that we've learned in the past, I really liked renal block the most.
Why did you choose UCSF?
Yeah, so well, one, it's always been a dream of mine to go to San Francisco. So I'm originally from Los Angeles. I moved down to San Diego for college, and it just seemed fitting that I go up north this time instead of south. So I really like the scenery of San Francisco. We've always thought that it was somewhere outside of California, even if it was in California. I also really like the cold, and San Francisco is really cold. 3-year curriculum is amazing. You get to go into workforce really early. Also, I'm a big clinical person, and UCSF is the first institution to find clinical pharmacy. So for those reasons, I chose UCSF. And then the question I have, a lot of these people that may be watching are first year students or students coming into UCSF. So tell us a little bit more about how your first years went. Like what was your daily life like? What'd you do? How was it? Was it difficult? Mainly in foundations and cardiovascular.
Do you want to go first? Do you want me to go?
I can go first. I would preface it by saying that my experience as a P1 or just experience in pharmacy school is actually very unique and different than most individuals here. Most people that my colleagues, they live actually in SF, and so they don't have as long of a commute that I typically experience day to day. I currently am situated in Alameda, that's across from the Bay Bridge, and so I actually have to bar in and take the Muni every day. And that commute takes anywhere between like an hour to an hour 30, and that's only one way. So round trip, it can range anywhere between 2 to 3 hours. And so with that, some people might be questioning whether or not it's doable or whether or not it's actually compatible with this very demanding lifestyle of having to balance school, but also like having to balance with like some extracurriculars. I will be upfront and say that I myself am not one of those that are super involved in school in terms of extracurriculars. I do, however, find opportunities to get involved. I'm part of the cultural club at UCSF called Taiwanese American Student Association, where we do a lot of and organize a lot of cultural activities. I help co-lead and teach one of the Mandarin elective courses with KO here, where she taught the the Cantonese arm of the elective, and I taught the Mandarin arm of the elective. And I'm also involved in some other different like projects or volunteer activities here and there between spread through different organizations. But all in all, I would say that P1 year is a year that you kind of really want to set yourself up for success in as you head into pharmacy school, because it's really important for you to build the basis and the foundations. And so typically I discourage, if people were to ask me, I would discourage people to like work while trying to do school, because you actually get a lot of those opportunities in P2 years as the demands of school kind of lessens a little bit, in the sense that there's less days for classes and more days for you to actually go out and actually take a job or gain some experiential learning. And besides, part of P1 curriculum, they also incorporates what's known as the introductory pharmacy practice experience. So you'll already be kind of working in a community setting. And so to add on another job on top of that with school is pretty difficult. And so I would say try to prioritize just your time, really trying to study for the foundations block, foundations 1, where they teach you the basic pharmaceuticals. And then also the first therapeutics block is really important, which is cardiovascular. And that really sets up the stage for all the other therapeutics that goes on afterwards. I don't really have anything else besides that. But...
Mind you, Brian has a lot of outside obligations that he did not mention, and this man literally spends every day doing something. He has no off days.
Very true.
Just, he's a very busy man, but he
Very
makes
true.
time. I don't know how he does it, but for me, at least I came from a very strong math background, and I personally did not think my math was very good at all. But I think for the math that you need to do in pharmacy school, I guess I would be considered good at math. So the first block for me, which was Foundations 1, very math based. So I thought it was okay. I didn't struggle too hard. Half of it was probably review, because I spent a lot of it. I did a lot of it during college. And so then I didn't learn PK/PD, pharmacokinetics, and pharmacodynamics when I was in undergrad, but those stuff is just building upon what we learned in college. So I think it was a lot easier for me as a chemistry major than a bio major, because I don't think you were doing that much math in bio. So I would say Foundations 1 is a lot easier for chemistry people because it's more math based. Obviously there's anatomy involved, but we all kind of know what a head is, what a heart is, those are more memorization based, so it's not as difficult as math, in my opinion. I also have to commute, not as far as Brian. I drive in from South San Francisco. I don't know if I'll just say this. I park near 10th and 12th for at least UCSF. Hey, free parking all day except on street cleaning days. And I'm just saying, free parking all day. You just gotta be careful with street cleaning. And then I just take the bus up. We get free passes as students, so it's not too bad. I give myself an hour. I definitely don't need to give myself an hour, but I panic if I feel like I'm running late. So that's just me. What else? For cardio, I enjoyed cardio. I think the hardest part for me was pathophys and physiology in general, because I'm not a biology major. I had a hard time actually understanding how the heart beats, whatever.
Both.
But once I understood, once you really get the pathophysiology, you understand the treatment, and then you just have to memorize the drugs and drug mechanism of actions. There are some unique, mnemonics that are here and there. But I think the basis is definitely pathophysiology, because that's when you truly understand what needs to be done. And it also explains guidelines, obviously. It was hard. We managed. We're here now. Yeah.
Yeah, these people are the people that I study with the most, and they're the people that I talk with the most. And I think we all have a very similar type of learning style where the more that we talk about it, even though we argue so many times about something so trivial like spelling or pronunciation. Talking to you, Kale.
I can't spell or pronounce anything.
That one. So even if we argue about those trivial things, I think it forces us to learn in a very specific way. Yeah. And then another question I had, so for me, I think the biggest tip I would have is know your learning style, know how you would learn. And like Kale mentioned, foundations is very math heavy, very concept heavy as well. And then when you get into your like cardiovascular blocks or these other organ system blocks, then it becomes something where you can systematically break down each component of your case. And that brings me to my next question. So, in pharmacy school and in real life, we have patient cases, right? So, you get a lot of these background on patients. So, you get their age, even regardless if it's a made up patient or a real patient, you get their age, their ethnicity, assigned gender at birth, and then you have all of these vital signs and labs and what meds they're on, right? So, looking back at it, right, we've learned a lot of these blocks. Hopefully, we've retained a lot of information. So we're in infectious disease right now, right? And my question would be, what's your approach in approaching a patient case, whether it be in cardiovascular or renal? Hopefully, try to make it more relatable in terms of cardiovascular, right? Since that's going to be their first block. But what's your approach in sort of breaking down a patient case and seeing what's the most pertinent problem and what you can do to treat it?
I don't know. I mean, we're not doctors, so we don't have to decide what we need. So in terms of labs, definitely look at anything abnormal. Obviously you don't know what abnormal is initially, but once you start working with a lot of these numbers, you'll start to remember, okay, this looks kind of funky, that looks weird, there's something wrong there. And for example, for cardio, like if the doctor's not suspecting MI, you're not gonna look at troponin really. So the only time you would ever see it really is if the doctor's suspecting something cardiovascular, and then you would see if you look at troponin and you see something funky, then you know, okay, that's something I should look at. Vitals, same thing. If it's weird, take a look at it. Usually if I'm given like a written case, I'll just go through, highlight every single thing that looks weird to me, and then the chief complaint. That is usually something I look at first because that tells a lot. If you're in a block, you kind of already know what to expect. If you're in cardiovascular, you're gonna be looking at the heart, right? It's easier that way. But in real life, the chief complaint is really your starting point, where whatever the patient is telling you about, that's probably something you have to look at because that's what they're complaining about.
Right.
Yeah, I think Kale touches this very interesting concept of like, why bother looking at someone's troponin levels if the doctor is not suspecting like a myocardial infarction or commonly known as heart attacks? In medicine, there's like this saying that like, correct me if I'm wrong, because I could be like getting this completely wrong. But there's this saying that like when you hear hoof sounds, you think of horses, not zebras.
That is a saying.
So this idea that like just because patient is presenting something, right, with something, you're not automatically jumping to conclusion and saying that, oh, they have like probably the least likely condition that they present with. You want to generally take the patient case, look at what their complaints are, and think of the most probable cause for those symptoms rather than jumping to conclusion and say, oh, just because they have like chest pain, it automatically jumps you to like heart attack or myocardial infarction. Maybe it's something else, So you kind of want to take it sort of step at a time. So for me, the first thing I look at is the history of present illness, is that like looking at what the patient's complaints are. And then from there, you can kind of gain a picture of what the patient might be having and experiencing. And then from there, you then go into labs and then kind of think about like, okay, what are some abnormalities in the labs, which you guys will learn. And don't worry, you guys don't have to remember like all the numbers, because even we don't know all the numbers to normal lab ranges. They will provide you with the sheet. But yeah, like compare the numbers, look at what's abnormal, what jumps out at you. See if you can make sense of like why the labs are abnormal given their presentation. That's actually one way of thinking that really helps you guys as you go through cardiovascular and also like further therapeutic blocks, because a lot of questions are going to get you to thinking, okay, why are the patients feeling this way? Why do they need more pillows at night to help them fall asleep if they have something like a history of heart failure? Why this and that, you know? Why are they presenting with a lot of thirst if they have like something like diabetes? So something like that. You kind of have to want to try to like piece it together and try to think of the picture, think of a holistic picture of what the patient experiencing as well as what the possible diagnosis might be.
And just to add on, like Keo mentioned that we're not going to be diagnosing these patients, and it's true, but we do have to understand if the medications that the doctors are giving are even indicated for this diagnosis. So even though we're not diagnosing, we kind of have to understand what the patient's presenting with. We kind of have to confirm the diagnosis that the doctors are making. And I really like what you said, history of patient
History of present illness.
present illnesses, looking at their labs and then highlighting the abnormalities in the labs. We remember some values. We don't remember all of them. I think we all can say we remember potassium values pretty well. Serum creatinine values you remember pretty well because we always look at them, right, as pharmacists. And I think that leads me to another point. So you're approaching this case as a pharmacist, right? Someone who is extremely knowledgeable about medications. There's a lot of drug-drug interactions, and there's a lot of things that we need to be worried about as pharmacists, including renal function, right? Liver function, and is it even right for the disease in general? So when you're recommending a drug, what is your approach in making that initial recommendation? And how can you back up what you're recommending, pretty much?
You want to add your input first?
Yeah. So I think looking at the patient's illness and confirming the diagnosis if it's real. So if a patient is presenting with chest pain and a heart attack, I know and we know in our heads what should be given first. And if a doctor prescribes something that's out of the ordinary of what we know, then I would look to see what that medication does and if it'll even help the patient in the first place. Mostly, I'm thinking about toxicities here. So I'm looking at it from a more conservative side. So I'm looking, okay, does this medication cause any important toxicities that I should be aware of at this moment, right? And if it does, then I'll discontinue it, and then that's end of story. But in terms of recommending, in terms of like an ambulatory care setting where these two might want to go in, and it's more they're taking it very chronically, then my approach has to be very systematic in a sense. So looking at what this medication does. So if it's like an insulin, theoretically, how many points does it drop their hemoglobin? And then how many points does it drop their sugar in general? So seeing if they're at risk for any other conditions like hypoglycemia is always nice. Drug-drug interactions, there's a lot of them. And I don't know all of them off the top of my head, and neither do these two. Interaction checkers like LexiComp and Micromedics give you a very good one. And it's your job as a pharmacist to determine, is that interaction something I should be aware of? Is it something that it'll cause a huge toxicity in my patient? So a good one is statins with grapefruit juice. We always know that one. So if the patient's taking grapefruit juice and the statin, like atorvastatin, it can really increase the levels of atorvastatin, and it can make them have more severe side effects. So I always err on the more conservative side when I'm recommending medications to give. But I try my best to understand and hold all of these thoughts in my head. So is it indicated for the patient? Are there any drug-drug interactions I should be aware of that are pertinent to this patient? Is it even correct for this patient? So those are the things I'm looking at. And then guidelines too. So your guidelines tell you a lot of things. And it's your job to interpret them and then apply it to your one specific patient.
I mean, I would definitely agree with the guidelines. Those are your go-to best friend to whenever you're deciding whether or not a drug is correct. Um, there are a lot of old doctors that will give like older guidelines, and they do work. Maybe not as good as what we know as current guidelines. So like I think there's some things there where like if the doctor insists on giving that one and there's no real bad consequence, we could still recommend, hey, we want this drug because it's been shown to be better. But if doctor only wants to prescribe that one, then okay, whatever, there's not much we can do about that. We are the final check in terms of giving medications, maybe like second to last if you're inpatient, because the nurse technically kind of checks too, but we are the people who give the drug out. And so you really have to take care of your patient and make sure no one is dying, or you're actually protecting the patient. Yeah, knowing that you're the last line really helps because you double check everything.
Yeah, I guess you guys touch on really good points because pharmacists, they are the pharmacotherapy experts, and so people look to pharmacists, and that's why pharmacists play such a crucial role, and they are actually one of the cornerstones to how a medical team functions, as they're the ones that provide a lot of these consultations. And a lot of doctors especially love having pharmacists that are very capable, very competent, and if you have a really good pharmacist, that team can go a long way in order to provide the most the highest quality of patient care. And yeah, like kind of what these two what KO and Emmanuel already mentioned, like it's really important to be detail oriented, definitely, for when it comes to recommending drugs. One thing I add on always, something that's often overlooked is like allergies. Like allergies is this something that I think people often miss, and actually someone's drug allergy history and their profile can tell us a lot, and it also can dictate how we want to best treat this patient depending on what their allergies are. And also, even with that, there are nuances because sometimes allergies are not true allergies. They don't actually really cause that big of an issue. And so, as always with pharmacists, we're always weighing the benefits and the harm, right? Does this therapy that we're going to recommend give more benefit or more harm, right? And depending on that scale, we may decide to go forth, even though there might be reasons for why we should not give this drug. Yet, if we look at it from a bigger picture, if this drug gives this patient a greater benefit compared to like risks, right? Risks and benefits, and we should give it to them because we're holding out from the patient something that they can really benefit from. And that could be really, really crucial and important when it comes to patient health outcomes. And so those are just some of the few things that we think about as pharmacists.
And this is a more sort of bleak topic that I want to sort of move on to.
Wait, before we move on, a big part of why I wanted to become a pharmacist was because I have a family that's let's just say medication avoidant. I mean, they will take their medications, but they will try everything else before. And so one big reason I wanted to become a pharmacist was to have this connection with patients. And I'm not trying to as pharmacists, we're not actually trying to give you these drugs. If anything, we want to stop your drugs. We don't want you to be taking these drugs. But one big reason I want to become ambulatory care pharmacist is so I can talk to these patients. And Brian earlier mentioned allergies. Yes, they might not be true allergies, but if it causes stomach upset, a patient's not going to want to take it. That's not going to help them regardless, even if you give them the drug. So you really, really want to teach these patients why it's important, but the final decision is really up to them. So you want to be in communication with these patients. You don't want to just give them the drug and be like, okay, bye, here's your drug, this will fix you. You really want to make sure that they understand why they need it, and that'll help towards them actually taking it. But again, we can't make them take it. We just need to help them understand, and so that the final decision is up to them. I want to be a pharmacist that provides the medication information to them, and whether or not they actually take it is going to be up to them.
I love the saying, you can lead a horse to water, but you can't make it drink. I think that's like my favorite saying.
Mm.
As a former educator and hopefully wanting to become an educator in the future, I can only teach you so much. And it's really up to you if you want to absorb all that material and do some extra things along the way. But if not, I can't, I'm out of my limits here. And that's the thing with medications too. I can only really give you these medications, and what you do after is really dependent on you, right? So I think that's one of the struggles that we face. And going into struggles, so we've had a lot of exams in pharmacy school. 2 exams per block, let's say, right? Maybe 3 sometimes.
That's not that bad compared to UOP. Yeah, UOP has like exams almost every day.
Every week.
But their exams are more focused on certain subjects. Ours are more like 3-hour exams. So exam wise time is
Mhm.
probably the same, but
So
Go ahead.
we two or 3 exams per block. We've had cardio, respiratory, renal, GI, 4. So we have endocrine,
neuro.
neuro, and then onc. So we've had 7 blocks, 8 including foundations 1, which is
Foundations
around
two.
16, 17 exams that we've taken, right? Which one was the hardest one, do you think? And have you, what's been the outcome? Have you failed any? If so, what happened? How'd you get back? Yeah. Just want to know more about exams, I guess, because
Mm.
they're about to be, you're coming in and hopefully you're excited, but you're fairly nervous about your first exam. So I kind of want to know what you guys felt like during that first exam, and then how do you overcome those obstacles if you had any?
Before we get into actually talking about that, I want to preface that the 3 of us came from really understanding our own learning styles. So
Mm.
we didn't have to struggle too much learning how to learn.
Mm.
A lot of students come in not knowing how to learn because college is not really preparing you for medical careers.
Mhm.
So it's very different that way. But we were fortunate enough to actually know how we learned, so we didn't have to struggle in that sense. But
Yeah, I guess to speak on my own experience, I've had to struggle with one particular exam,
Mm.
but that exam was the very first therapeutic select exam that we had. So that was the very first exam for cardiovascular block. It's the first block that we are exposed to learning about clinical sciences.
It's also the only block he didn't study with us. No,
wait, I didn't study with you guys and like really study with you guys
That's
until
true.
like the second year.
That's true,
Second
that's
year?
true,
Yeah,
that's true.
maybe. But yeah, that block was particularly difficult. Just because you're not real. I mean, granted, we were not sure what it would look like.
Mm.
It was the first exam that ever touches on the topic of clinical sciences,
Mm.
and I think my way of thinking about how to approach a problem at the time was incorrect.
Mm.
I was very keen set on looking at the numbers and then associating that with the patient rather than treating the patient as a whole.
Mm.
Again, there's this saying in healthcare that you're treating the patient, not the numbers,
Mm.
right? And so like maybe like sure the patient's lab may come back abnormal, but if they're not experiencing anything, why give them a treatment,
Mm.
right? If they're not experiencing like any complaints, like why treat them? Now, of course, there are certain diseases that might be silent killers, like hypertension, where patient might not necessarily feel right that they're sick, but for the most part, we can say that like a lot of these these patient cases that we're given in pharmacy school are cases where you're going to have patients that complain of something and you're gonna probably have to treat it.
Mhm.
And I think, yeah, another thing I would add is that it's okay to feel nervous. It's okay to feel like worried or uncomfortable. That's all part of like learning,
Mm.
right? Like if you're not uncomfortable about the content that you're learning, then are you like really learning,
Mm.
right? Like that's something that I learned from my professor from the very first day of pharmacy school, and that's something that I continue to kind of think about as I go into like future trainings. Cause like, yeah, why am I doing this thing that I already feel comfortable with, right? Because if the idea is to become the best pharmacist that I can be, not necessarily the best ever, but just the best that I can be. Like I wanna be exposed to various areas of practices that I want to learn more of and to actually become a more well-informed and well-trained pharmacist and be able to help my patient in that way. And so I will say that and that it's okay to feel nervous, it's okay to feel like worried, but do what you can, ask questions, and really don't be afraid to reaching out. I think that's something that I feel like I felt a lot in college and even into pharmacy school is like, oh, I feel kind of sheepish about asking questions because I feel like, or because of this notion that, oh, everyone else probably already knows. That's probably not true. If you have a question about it, someone else probably has a question about it. And so, yeah, really use those opportunities to ask questions, and really find like, your group of friends or just people that you can really that have similar learning styles as you, and as you find those groups of people and as you guys spend time together studying, like at the end of the day, like you got people that are helping you and trying to help each other succeed in that way. And so yeah,
I realize this podcast has just been a quote sort of podcast. We've given you guys like 4 quotes. I think Brian has given 3. I've given 1.
I've given none.
You've given none, but now this is your time. What are
I
your
don't think I'll
thoughts,
have a
Kale?
quote still, but I think when I first came in, the professors really scared us into like, oh, you need to change your learning habits. You need to do this, this, and this to actually succeed. If I don't know, okay, I can only think of 2 things that they've told us: learning objectives and what was it? Or like learning objectives and like I forgot the other actually. But I don't actually really use the learning objectives. I like, so what I've learned is, study the way you think is best for you. If learning objectives don't help for you, don't use them. Just don't. I mean, but of course, if they help, use them. If you are struggling, then try different ways. Try using the learning objectives, or maybe it works, maybe it doesn't. Also, like, don't conform to what other people say you should be doing. Like, I always grew up thinking that if you participate in class, you're gonna do better. I don't really participate in big lectures, but I talk my head off during small groups. So like Brian can confirm, I just kind of babble during like small groups, and like whatever comes to mind, it just comes out.
And it's the worst. By the way, if you ever get in a room with Kale when she's having one of those spurts, I apologize on her behalf. I don't know if you understand, but some of the things she says just doesn't make sense.
Sometimes my brain just works too fast over my mouth, and it doesn't, my brain is already on the next topic, but my mouth is struggling to keep up,
that's why we talk things out.
Yeah.
Exactly.
And-
Or, writing things out. That's better. Like, they tried to push me into like, studying with them initially, but no, I have my set way of studying, which is studying by myself first, so that I actually know what's going on. Then we can talk about things. So don't conform to other people. Do what you think is best for you and what actually works for you. That's my only thing.
And actually, if you go back, you'll hear a portion of this when she has one of those spurts where she thinks ahead and then she just blurts out whatever she wants to say. So you'll actually see it, and then you'll be like, okay, now I understand why. But for me, I study best when I'm teaching people, and because it forces me to understand what I'm truly teaching, and there's a lot of pressure on me to teach them because hopefully they're as receptive to teaching as I'm fortunate enough to actually teach them. So if they're absorbing this material and I'm giving them the wrong material, not only am I messing them up, but I'm also messing myself up. I'm also living in like a false truth. If I told them that, oh yeah, with the heart attack, you won't see a troponin increase. No, you won't. I'm only feeding them the wrong information, and I'm only etching down that information for myself, and it's wrong. So I really like teaching others, and I love talking things out. I think for me, I don't do well when I'm writing because honestly, my hand kind of hurts
Oh, yeah,
when I'm like writing my
Yeah.
notes. There's a lot to write down.
yeah.
I love to type, but I always do that, right? It's like after classes, I always type out my notes. So a lot of it is just us talking and sort of correcting each other whenever we hear something that's like not completely correct or something that can be improved. Because the way I answer these questions on an exam is the way how I would teach it and how I would talk to you all, right? Otherwise, unless it's like a multiple choice, then that's like, okay, if you know, you know, if not, then sorry.
Also, exams can be wrong. We found multiple errors on exam. So just because if you are like 100% you're right, you think you're right, there's a high chance you probably are.
Yeah.
Because, our professors make mistakes. Not everyone's not perfect, but
And I think that just goes to show that like a lot of people are prone to making mistakes, and we've made mistakes a lot. And I'm fortunate enough to have like a good support group in these two where they accept me for being loud and very ambitious, like starting this, right? I just said, okay, we're gonna start today, and they're like, okay, fine, we'll go in it, I guess. So they're very blind, they're very allowing, and they allow me to be myself. We're almost out of time. Any last words for these before? So the next podcast, I'll come up with a patient case and we'll talk about it together. Any last words for them before we move on to the next one?
You got a quote?
You got a quote? Let's
no,
take
but I have a
quote.
correction. Earlier, Emmanuel said insulin lowers your hemoglobin, and I'm like, hemoglobin what?
A1C.
He forgot the A1C, and I was like,
Sure.
other than that, I don't have much to add.
That's why you're closing. Wow, thank you.
I was
Thank
going
you.
to correct you then, but then
No,
you moved on, so
You're
then
good.
whatever.
Good. Anything from you, Brian?
Just enjoy your time here. I
Mm.
think 3 years is too short to be always thinking about your career. While that's all good and important, really find a community, find people that you can trust and talk things through. I'm very lucky and fortunate enough to find people like Emmanuel and KO and several others who are not in this room with us, but just really try and go out there. Don't be afraid. Take advantage of orientation. And also congrats if you're seeing this podcast because it probably means you made it. So yeah.
Wait, if we do a two, it'll be like a
Do we do it too?
yeah, it'll be like a
What is
something like a balloon.
What?
It'll be a
What?
balloon. You'll see
That's
it.
FaceTime.
Yeah, not Zoom. I was like, wait.
Oh, last time I did it was on Zoom. Okay. Yeah, like Brian said, congrats if you made it here. And congrats if you didn't make it here, but you made it to another pharmacy school, right? I think pharmacists are really needed in the workforce. And yeah, we're done. Bye everyone.